It's very kind of you to invite me. I actually didn't come for this. I came for the rugby, which is far more important. And I hope you'll all be supporting England next Saturday. I actually used to play rugby. This was me when I played for Cambridge University. And I put this up because it's quite an amazing journey, isn't it? Because when I was playing rugby then, hepatitis C didn't exist. It was non-A, non-B hepatitis. And in 30 years, it's amazing how we're talking about eradication of a disease. And you've seen the kind of almost uniform positive response to DAA therapy. And of course, as doctors, when we have something successful, we tend to be rather negative about it and think about what obstructions are there to actually receiving this treatment. One of which, of course, is special populations. And special populations we all love to talk about. But special populations, I hate the idea of special populations, and it would be very easy for me to put up 100 slides showing almost 100% response in these special populations. So here it is. If you look at hemodialysis patients, up to 100% response. Co-infected patients with HIV, 100%. Liver transplant, 100%. And certainly if we look at our own cohort, these special populations, such as the HIV positive population, actually have a higher response than the HIV negative population. So I try and get away from the idea of special populations and think of some of the true barriers. And I think one of the true barriers we have to eradication, to elimination, whatever you want to talk about, is the risk of reinfection. And this is certainly one of our patients who you can see has been not reinfected 1 time, 2 times, or 3 times, but has been reinfected and treated 10 times. So many people will say, is this truly reinfection? Is this relapse? People have talked about the hepatitis C hiding in the brain, hiding in the liver, in the PBMCs, or even in the genital tract. I think all of this is untrue. This is a treatable disease, a curable disease, and it's about preventing individuals from getting reinfected, because reinfection after successful hepatitis C treatment is clearly going to be important. It's going to be important because it's going to reduce the cost benefit of treating with, certainly in our country, are very expensive drugs. It clearly illustrates the need that it's not just about giving people drugs, but also about education and prevention packages as well. It tells us that we need to continue screening for hepatitis C even after successful treatment. And it shows us the idea of the fact that even when we can treat successfully, there may be still risk of transmission from this reinfected population. Now, I think when we originally talked about reinfection, the group of individuals we were worried about getting reinfected were people who inject drugs. Interestingly, if you look at the rates of reinfection in this population, it's actually relatively low. If you look at studies such as C-EDGE, you can look at the rate of reinfection, and clearly this shows the need of trying to prevent people from continuing to inject drugs. If you look at the rates of reinfection of those continuing to inject, it was around 4 per 100 person years, compared with less than 1 in individuals who'd stopped injecting. So when we talk about the introduction of DAA therapy, it's not just about treating people, it's also putting packages of prevention in place. Packages such as opioid substitution therapy, needle and syringe programs, which have both shown that they may reduce the risk of hepatitis C infection by over 50%. Unfortunately, if you look on a global level where we're talking about elimination, eradication, about rolling out DAA therapy, the percentage of individuals who are able to receive these packages is incredibly low. So get away from the idea it's all about rolling out drugs. It's also rolling out education and prevention packages and giving individuals support. It's supporting the individual who is living or has lived with hepatitis C in the future. We need to give counselling around safer injection practices. Many of these individuals also have mental health issues. We need to make sure that these are provided and individuals engage in them, and also the idea of social support. And again, if we look at the effects of mental health counselling in this population, again, we can see by rolling out these programs alongside alongside DAA therapy, that we can actually reduce the rates of infection. And I love this idea, this is from Canada, about the four-legged chair theory. So if you all think about your chairs you're sitting on, they've got four legs. Imagine if one of those legs was taken away, and what would happen to you. And it's the same when we talk about individuals with hepatitis C. We need to look at their medical needs, we need to look at their addiction-related needs, their mental health and social needs. And it's about getting all of these in place if we are truly going to deliver effective programs. The other group where reinfection has been an issue is in the men who have sex with men. And certainly we've seen in London for many years an epidemic of hepatitis C being transmitted, principally initially amongst HIV infected, but now amongst HIV negative MSM as well. And what happened when we first reported this is that it was totally ignored. People said it was never going to happen in their countries. They put their heads in the sand, and very soon we had an epidemic throughout Europe. What happened outside Europe? People to continue to live in denial, said it wasn't going to happen there, and from this small start in London, big things have happened, and it's now a global epidemic. Is it happening in Asia? Well, when I first came to Asia, they said it wasn't happening here, and of course now there are reports in the MSM population of an increasing hepatitis C incidence in Taiwan, here in Japan, in Korea, and in Hong Kong. So this is a truly global epidemic. So where's it coming from? It's not coming from blood, it's not coming from injecting of drugs, it's not coming from tribal practices such as we see in Africa, it's not coming from tattoos. Now, being British, we don't like to talk about sex, but this is a sexually transmitted infection. And people really didn't like the idea of this. They didn't like the idea that hepatitis C could be transmitted sexually. And a lot of that was based on the heterosexual population. If you look at studies in the heterosexual population, it's difficult to transmit hepatitis C. This is some data from the partner study, which would suggested you would have to have sex 190,000 times to transmit hepatitis C. Now, one of my medical students is much cleverer than that, because when I said, how many times do you have to have sex to transmit hepatitis C, she very cleverly said once. And that's the truth, isn't it? It's a game of risk. Think about the millions of people living with hepatitis C worldwide. There clearly is going to be sexual transmission to a certain extent, even in the heterosexual population. What about in the homosexual population? This is a nice little study looking at biological plausibility from Daniel Fiera. He looked at rectal levels of hepatitis C. He showed good correlation between the magnitude of blood levels and rectal hepatitis C. He then went on and did this little bit of simple mathematics. The infectious dose of hepatitis C in blood is 10 to 20 particles. Based on the median rectal hepatitis C viral load, the average size of a circumcised penis, you would be exposed to more than the infectious dose of hepatitis C. So it's plausible that this could be transmitted sexually. Okay, so we have plausibility that it may occur. What about the evidence in clinical practice? This is a study from London looking at risk factors for hepatitis C transmission. This is looking at a co-infected population compared with a hepatitis C negative, HIV positive population, looking at various different factors, and this is a matched population. So what did we tease out from this? First of all, people were meeting individuals for casual sex. They weren't meeting over dinner, at a party. They were meeting principally over the internet purely to have sex. They were having multiple sexual partners, and those people becoming infected with hepatitis C, having significantly more sexual partners over the last 12 months. They were getting up to different things sexually. So if you look at those individuals who were becoming infected, they were much more likely to have unprotected anal intercourse, both receptive and insertive, much more likely to have oral anal sex, insertive fisting, putting the hand and arm into the rectum, higher use of sex toys. And that was principally not only on an individual basis, but also on a group sex basis. They were much more likely to have utilized drugs. And we're not talking here about intravenous drug use. We're talking here principally about nasal drug use, sniffing of drugs, and the sharing of straws, and potentially, I suppose, blood. There was also a higher risk of sexually transmitted infections in the last 12 months, principally those infections which would break down the rectal mucosa, syphilis, gonorrhea, and chlamydia. So what we're seeing in this population is hepatitis C transmission, individuals meeting partners casually, having no idea of their background, undergoing high-risk sexual practices, utilizing drugs, shared routes of transmission, and also having more sexually transmitted infections. And this idea of these being the risk factors for transmission of hepatitis C has been confirmed in studies from Australia, from Germany, and from the United States of America. And so what we have to realize is over the last 10 years, there's been a massive change in the population and what young people are getting up to. The gay scene is highly sexualized, not just in the United Kingdom and Europe, but increasingly on a global scale. People are not using condoms anymore. You know, the idea of PrEP, HIV not being transmitted when your viral load's undetectable means bareback sex, sex without condoms being much more common. What people are getting up to, both sexually and as regards drugs, has changed dramatically over the last 10 years. And if you go to bars now, it's very different from what it was 10 years ago. The use of drugs, the use of heavy amounts of alcohol has almost become normalized. And drugs are being used to facilitate sex. Sober sex can be increasingly challenging, particularly for young people entering this highly sexualized group of individuals, and they're using drugs to facilitate the sex. And it's a case of having to fit in with other individuals within these groups. And so what's happened is that there's been an evolution of substance use within the gay scene, and as you will see, increasingly in the heterosexual scene, leading to different and more diverse sexual practices. If you look at individuals who have become infected with hepatitis C, this is a cohort from Berlin of men who have sex with men, over a third were using drugs intravenously. And this is something which is increasingly being recognized in this group. They don't consider themselves as intravenous drug users, they consider themselves as individuals who use drugs intravenously on a very occasional basis. But there is an increasingly amount of use of intravenous drugs in this population. If you look at the UK population of MSM, over 50% will have used these recreational drugs over the last 3 months. And as I said to you, it's increasingly being recognized that this is also the case in the heterosexual population. This is data from London, again, looking at the use of drugs, recreational drugs in heterosexual females. If you look at MSM, it's around 40% in heterosexual females. Using in the last 6 months is 25%. So this is not just an MSM issue. It can become an increasing issue also in the heterosexual population. So again, a great deal of work needs to be done on prevention of transmission, not only of hepatitis C, but also of other sexually transmitted infections. Certainly, if you look at your HIV group and their risk of becoming reinfected with hepatitis C, you can see how much higher it is than the intravenous drug-using population. And if you remember the figures that we showed, it was around 1 per 100 years. If you look at Paris here, it's 20 per 100 patient years. London, between 5 and 8 per 100 patient years. You know, the idea of reinfection is much higher in this patient group. Again, you could say, are you sure? You know, these are immunosuppressed individuals. Are you sure it's not relapse? Well, here's a phylogenetic graph of individuals who've become reinfected. You can see these two patients actually being quite close together, but that is because they got it from the same sexual partner. Other individuals who have become reinfected, you can see within the phylogenetic tree, they are a long distance apart, showing that these are truly reinfections. And so if we look at our reinfection rate, this is throughout Europe, this is a cohort of individuals with acute hepatitis C, the reinfection rate was around 7 per 100 patient years. However, once you've become reinfected once, you are much more likely to become reinfected a second time, showing the importance of dealing not only with the virus, but also of dealing with behavioural practices as well. And so we have the ability to treat, and when we treat, we may get fantastic results, and that may be for several reasons. We may be able to reduce, if you like, the reservoir of hepatitis C, but there may also be individual patients out there who are responsible for a large number of these transmissions. Certainly early on in the DAA era, this is data from Amsterdam, you can see over 2 years how by rolling out DAA therapy, they were able to reduce the rates of acute infection in the MSM population. And that was nothing to do with changes in behavior. If you look at the rates of syphilis, they remained exactly the same. Now, the problem we had in the United Kingdom is that these drugs were not made available. All right? You could only get these drugs on a waiting list, and it was the sick patients who came first. The only other way of getting hold of the drugs was to buy them yourself. And for some people, the majority of individuals, that despite buyers' clubs making them available relatively cheaply, was unaffordable. And that's a shame, because if we look at direct-acting antivirals and their effect not only on chronic hepatitis C, but also on their ability to treat acute hepatitis C, it's really quite impressive. This was the first study done looking at Harvoni in acute hepatitis C, with a response rate of around about 80%, perhaps slightly disappointing. I think this was because if we look at some of these individuals, they had very high viral loads. They were treated just for 8 weeks, and what we actually see is it's at those patients with very high viral loads where the difficulty in treatment occurred. With 8 weeks of the Merck combination in acute hepatitis C, 98% response. And we've just finished a study called Target 3D. These are the results of phase 1, looking at 8 weeks of Maraviret, showing again per protocol 100% of patients responding. Now, what's just been published is this. This is the second cohort from Target 3D, looking at 6 weeks of treatment. And again, if we look at 6 weeks of treatment with these second-generation DAAs, again, you're approaching 100% response rate. So it may be possible to give very short courses of hepatitis C therapy in acute hepatitis C. Again, we need to be slightly wary. The one patient who relapsed had the highest viral load entering the study. But we've seen these results of positive results with Maraviret at 8 weeks and at 6 weeks, and we're about halfway through the final phase of this study, looking at 4 weeks of treatment for acute hepatitis C. So I think the important message is to remember that hepatitis C is not just spread through blood and intravenous drug use, it's also a sexually transmitted infection. To deal with this adequately, it's not just rolling out direct antiviral therapy, but also effective prevention and education strategies. And I think a lot of governments are doing that now. They're recognizing that countries are having increasing problems with so-called legal highs, these chemsex drugs, which are being used as party drugs. And I think it's quite clear if you look at modelling that just rolling out direct-acting antiviral therapy is not going to be successful at eradication or elimination. It's also about changing people's behaviour. And certainly if you look at how these drugs are being made available, that's also going to be important. These are the treatment pathways in the UK. Initially, you could only get these drugs, as I say, by waiting on the National Health Service. Then we had this rollout of large numbers of clinical trials. That meant we were able to treat people with acute hepatitis C much earlier. Therefore, they were adding to the reservoir of hepatitis C for a much shorter amount of time. And if we look at these results, if we look at new infections, we can see this dramatic fall in new infections in the MSM population, although reinfections stays exactly the same, where we haven't concentrated enough on trying to change individuals' behaviours. People have been worried about PrEP. Was the evolution of pre-exposure prophylaxis for HIV going to lead to increased incidence of acute hepatitis C? Most studies have not shown that to be the case. What's more important is when we actually have education and prevention programs, it's no use doing it in the short term. Doesn't matter what group you look at, you can see an initial effect on reducing hepatitis C reinfection in the first year, but when these programs stop, people become rather blasé about delivering the programs, not turning up for the programs. You see then an increase in the rate of reinfection. So finally, I'll leave you with this. You know, hepatitis C is associated with cure. But it comes at cost, and we need to be aware that these drugs in many places are expensive, and there are still challenges, not as regards successive treatment, but preventing reinfection and new infections to prevent us actually achieving elimination and eradication. Thank you.